Good afternoon and welcome to today's Public Health Ontario Rounds presentation entitled Rethink the RX, Reducing Unnecessary Antibiotic Prescribing in Primary Care. I'm Brad Langford. I'm a pharmacist specialist at Public Health Ontario, and I have the pleasure of moderating today's session. I'm joining you today from the traditional territory of the many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it is now home to many diverse First Nations, Inuit, and Métis people. As we are joining from a virtual platform, I welcome you to reflect on the land in which you work and live and acknowledge the traditional owners and caretakers of those lands. This week is World AMR Awareness Week, a global event to recognize the growing public health threat of antimicrobial resistance and the importance of working together to reduce the emergence and spread of these drug-resistant organisms. So I invite you to spread the message during World AMR Awareness Week by visiting the website amraware.ca. This is a new national campaign called AMR Aware Canada. There you'll find lots of campaign resources to help spread the message about antimicrobial resistance with clinicians and with the general public. During World AMR Awareness Week, there's also a color campaign aimed to bring visibility to AMR called Go Blue. Participants are encouraged to wear blue during the week, visit landmarks across the country that will be illuminated in blue, use the blue color on your social media backgrounds, webinar backgrounds like this one, and share with family, friends, and colleagues as to why going blue is important to you. So before we begin, I'd like to mention a few housekeeping items. I'd like to start by disclosing that I have no conflicts of interest to declare or to request CME credits. Please email capacitybuilding@oahpp.ca. And so I'm now very pleased to introduce today's speaker, Dr. Jennifer Young. Dr. Young is a comprehensive family physician who works in Collingwood, Ontario. In addition to her clinical office practice, she looks after patients in the hospital, does low-risk obstetrics, and is associate professor with McMaster Family Medicine. She teaches residents and medical students there. She is a part-time physician advisor for the College of Family Physicians of Canada and a member of PEER and is the CFPC liaison with Choosing Wisely Canada. So with that, I'd like to turn it over to Dr. Young to get us started.
Thanks very much, Bradley. Yes, as you've mentioned, I'm here to talk about rethinking the prescription, reducing unnecessary antibiotic prescribing in primary care. Very happy to be here, and thank you for having me. I am in Collingwood, and this was the territory of the Tiantati and the Haudenosaunee, and I very much appreciate the land in which I'm able to hike and share with my family and encourage my patients to also share in the beauty of natural world. So my disclosures are, as mentioned, my only financial association is that I am a part-time employee of the College of Family Physicians of Canada. I do receive honoraria for speaking with the Ontario College of Family Physicians, PEER, and PIPE, but I don't receive any income from financial or from the health and pharmaceutical industry. So during this 45 minutes and with questions afterwards, I will be talking about common scenarios of antibiotic overuse in primary care settings. I'll identify practical tools that support the judicious use of antibiotics and look at some other antimicrobial stewardship strategies for improvement in practice. I am a family physician who works comprehensively with cradle to grave care. I used to work in the Emerge, work in after-hours clinic, and so I'm intimately familiar over the many years of my practice with all of these challenges, both doing it incorrectly and hopefully decreasingly incorrectly, and using my patients as allies in antimicrobial stewardship. So should we care about it? Yes, 23 million antibiotic prescriptions annually. Antibiotic resistance is increasing, and I can have a slide about one specific example later. And the WHO indicates that it is one of the top 10 threats for global health in 2019. We really want to keep antimicrobials as something that will save lives, and the more we use them inappropriately, the less available they are to help us save lives. Antibiotic use in Ontario. A study in 2020 of 341 physicians, family physicians, or community physicians, about 500,000 encounters with about 150,000 antibiotic prescriptions, was found to have an unnecessary prescribing rate of about 15.4%. And the conditions with the highest rate of unnecessary antibiotic prescribing were bronchitis, just over 50%, sinusitis around 50%, otitis media around 40%, and pharyngitis just over a third. There is also evidence around prolonged duration. In English primary care database estimated that between 2013 and 2015, there are approximately 1.3 million excess days of antibiotic use. And a separate observational study looking at pneumonia found that 2/3 of pneumonia cases were treated with excess duration. And for each excess day, there was an associated 5% increase of an antibiotic-associated event. So let's go with tools. I know many of you know the right thing, and it's just what kind of tools do we have to help us do the right thing. The cold standard is something that Choosing Wisely Canada and the College of Family Physicians of Canada designed in 2019, and it's been updated. This is the most recent edition, is the fifth one, 2023, and it's got some it's not a long toolkit, and it has some excellent tools that I will show to you. So this is one that I will zoom in on. It's a one-pager that has matching the respiratory symptom with the most appropriate approach. And it has all of the conditions down the left, specific situations where they would be recommended, the recommended duration, and then tools to support management. So I have cut out sections of this, and so these slides that follow are the ones that are sections of that last table. So otitis media, specific situations where they are recommended, would be a perforated drum with purulent drainage, and a bulging drum with either a high fever, moderately or severely ill, or symptoms that are greater than 48 hours. So you can give you can give an otitis media about 48 hours to resolve on its own. That is in the greater than 2 years of age. So the recommended antibiotic duration in kids 6 months to 2 years is 10 days, but greater than 2 years, it's 5 days. And the recommendation for supporting reduced antibiotic use is a delayed prescription if they are greater than 2 years of age. And what that means is saying to somebody, I'm looking at, and just did this just yesterday, looking at your child's ear, and they are not overly sick. Their temperature is less than 39. They've had it for a day or so. And I say, we could probably give it a little bit more time, but here's a prescription to fill in these circumstances. So I actually create a prescription. I print it out, I give it to the parent, and they have instructions for filling that prescription under the circumstances that are outlined in this delayed prescription piece of paper. This one is available on in the Choosing Wisely's Cold Standard. It's also available if you were to just Google delayed prescription Choosing Wisely, it would come up, but I would suggest you have the Choosing Wisely toolkit on your desktop. So when we looked at the data around the benefits of a delayed prescription, there is a recent Cochrane 2023 that looked at this strategy. And when they say no antibiotic, what they mean is you say to them, I'm not going to treat your ear infection, for example, today, but if things are not getting better in 2 days, come back and see me. That's the no antibiotic approach. The delayed antibiotic approach is the one I described, where you print off a prescription and you give it to the person, and the person or the parent, and they fill it if necessary. And then the immediate prescription is obvious. It's you give the prescription right at that consultation. So the antibiotic use on the left here is in the immediate prescription, more than 90% of people fill that prescription. In the delayed prescription, where you have given them the prescription, only about 30% end up filling it. And in the scenario where you say, come back and see me, the amount is just over 10%. It's about 13%. They looked at patient satisfaction in this middle group of bars. Satisfaction was 90+% in the immediate. It was just under 90 in the delayed, and it was just over 80 in the come back and see me scenario. And those were not the statistical difference was, there was no statistical difference between the delayed prescription and the immediate prescription. There was a difference between the delayed prescription and the no prescription, and also the no prescription and immediate prescription. So people were not as satisfied with that come back and see me if you're sick. Still sick. But interestingly, the reconsultation was just around 9% for both, a little bit more for the ones who were told to come back, but the no difference in reconsultation between the delayed and the immediate prescription. So when you consider, are you going to do the observation, like come back and see me versus delayed prescription, what is your availability for follow-up? Can the person travel? Can they be relied upon? Is there an understanding of what's going on? So it's not necessarily the right approach for all scenarios, with that being the one where you say, come back and see me if you are still unwell. Pharyngitis. So pharyngitis, the vast majority are viral and they feel terrible. And people want antibiotics for it. They're sure they're going to get better way faster with them. But there are criteria that we use for it called the Centaur score, which is well known likely by most of you. But if it's greater than or equal to 2, and the throat swab, the rapid strep, is positive, the recommended antibiotic duration is 10 days. But if the Centaur score is less than or equal to 1, if it's clearly a fully viral picture of runny nose and a cough, a positive swab in this situation is likely colonization. So I have run into this situation very frequently where it's clearly a full-on viral coryza situation. You do a swab, the throat's barely red, and it comes back positive. So don't even do the swab if you've got that circumstance of a clear viral coryza situation. So tools to support you using rapid strep. I do have a rapid strep test in my office, and most walk-in clinics have them, and it's very helpful to help guide your management. The viral prescription is a tool that we use. So you have a viral illness, and here are symptoms, things that you should do for that. And these are available in EMRs. They're available on RX files, Choosing Wisely Canada, part of this toolkit. And there's also a viral prescription for children. So sinusitis, as indicated on the earlier slide, it's one of the most commonly overprescribed conditions where people get antibiotics. By the way, green stuff coming out of your nose and green stuff coming out of your chest is not very specific for bacteria. Many people think that it means it's become a bacteria, not necessarily so. So with sinusitis, you need to have 2 of these PODS criteria. So that the PODS criteria is facial pain, pressure, or fullness, nasal obstruction, purulent nasal discharge, and a sense of smell that is reduced or absent. So if they've got 2 of those, one of them being obstruction and purulent nasal discharge, and their symptoms are greater than 7 to 10 days, or very severe, or no response after a 72-hour trial of corticosteroids, then the recommended antibiotic duration in that scenario would be 5 days. As indicated, though, the vast majority are going to be viral, and you can use a viral prescription. And nasal corticosteroids. So nasal corticosteroids, again, with coryza, we've looked at, there's been studies that look at that, plus an antihistamine, and really the nasal corticosteroids are superior, and antihistamines don't actually add anything to that. So pneumonia, you need objective evidence. Physical examination alone is not sufficient, and a wet cough or crackles on exam are not diagnostic. Don't prescribe for a so-called pneumonia unless you have a chest x-ray that confirms the presence of a new consolidation. So normal vital signs and no findings on physical exam, there that negative predictive value is very high. So you don't need to do a chest x-ray if you have normal vital signs and no findings on physical examination. If you do diagnose pneumonia, you have compatible symptoms and chest x-ray confirmation, 5 days of antibiotics, and 5 days of antibiotics is the duration of treatment, which is a reduced amount than what most people are getting. So 5 days has been looked at in systematic reviews as being an adequate course of treatment for mild to moderate community-acquired pneumonia. The exacerbation of COPD, that would be where there's an increase in sputum purulence with either increased amount of volume of sputum or increased dyspnea. The antibiotic duration for those are 5 days. And of course, steroids if they meet criteria, and their ongoing inhalers for their management of their underlying disease. Bronchitis, in quotes bronchitis, and I say, everyone said, do I have bronchitis? Well, I try to just reframe it as you have a chest cold as opposed to bronchitis, because immediately the association with bronchitis is antibiotics. So a chest cold or a treatment of an asthma exacerbation, antibiotics are not indicated. I want to spend some time on bronchiolitis. Bronchiolitis is a viral infection, as we know right now. We're right in it. Wheezing and respiratory distress in children who are less than 2 years of age. The treatment for it is symptomatic, and there is no indication for antibiotics. And by the way, also no indication for bronchodilators or corticosteroids. And choosing wisely has also put together a really great toolkit that we published last year that goes through the evidence and goes through these next slides are drawn from that toolkit, so bronchiolitis toolkit. The double harm of chest x-rays, and the reason that I mention chest x-rays is if you listen to the child who's got bronchiolitis, you're going to hear bilateral wheezing, typically, and sometimes you're going to hear crackles. And if in the right clinical scenario, if you have the diagnosis, you do not need to do a chest x-ray. And the diagnosis, and there's double harms of doing the chest x-ray are that it's unnecessary radiation. The chest x-ray and then as having a chest x-ray done, you're more than 10 times likely to be prescribed antibiotics, because false positives are misinterpreted as pneumonia. And how many of us have seen those nonspecific atelectasis, nonspecific thickening, and bilateral, and it's could not rule out a bacterial infection. Those ones will lead to an antibiotic just about all the time. So just don't even order it. You will be much less likely to prescribe an antibiotic in a scenario where it is clearly the bronchiolitis presentation. There will be other scenarios that where you have unilateral findings or a very high temperature. Those would be ones where you might suspect that there could be a different bacterial infection going on, and a chest x-ray would be indicated. But in that classic scenario of 4 days of runny nose, a bit of fever, and then they're starting to be wheezy and more coughing and short of breath, and you listen to their chest, and they've got bilateral wheezing, they've got some indrawing. Those are your classic, and in the right age group of 2 years, around 2 years or less, that's diagnosis you've made clinically. So what are the barriers to not prescribing antibiotics for viral infections in your practice? All of us know the right thing. It's just a question of how do we do it? Well, I've always done this. Time constraints. The patient wants it. Those are the two most common scenarios. And also the uncertainty, better to do something, to do nothing. So what about these patient and caregiver expectations? A study looked at whether physicians guessed correctly if they thought a parent was looking for an antibiotic. They were wrong about 50% of the time. So we're a little better at knowing if parents did not want antibiotics, but we're about half the time wrong when we thought they did want antibiotics. But if that doctor thought that the parent wanted an antibiotic, they prescribed antibiotics 2/3 of the time versus 7% of the time when they did not think the parent wanted it. And this is in the scenario of a viral infection where the diagnosis that the physician had made an ascertainment that they felt it was more than 90% likely to be a viral presentation, there was still that antimicrobial prescription. So parents are looking for clear information about the diagnosis, a good examination, good history, a good physical, elicitation of the concerns, but then advice on symptom relief, reassurance, and then a contingency plan. What do you do if? What should I come back for? What about this? It takes too much time. This particular study looked at 3,700 visits to U.S. primary care practices for these upper respiratory illnesses and found antibiotics were prescribed 2/3 of the time. When the antibiotic was prescribed, it took them 14.2 minutes, and when it was not prescribed, it took them 15.2 minutes. So that's respiratory illnesses, one that we're dealing with right now and an ongoing challenge. And I just exhort you to try to use these toolkits that will help you with things to communicate with parents, communicate with patients around their presentation and the risks of antibiotics and what a follow-up plan would look like. Other things to do besides antibiotics. So I am going to move away to a new toolkit, and these are Choosing Wisely is pumping out some great toolkits these days. This is just published literally yesterday. It's a new toolkit for dentists and community providers about tooth pain. So the target audience is dentists, physicians, and other healthcare professionals who are managing adults with tooth pain in settings where dental treatment may or may not be immediately available. So it was originally meant for dentists, but I was brought into this toolkit because of really the huge amount of dental prescribing that goes on in a dental infection, dental antibiotic prescribing that goes on in emergency and in primary care. So we need to reduce the inappropriate prescriptions for antibiotics for tooth pain. So in non-dental settings, pain with or without localized setting, the recommendation is pain management and dentistry follow-up. If there is pain, like you can even have a little bit of an abscess at the bottom of a tooth, still it's pain management, and they can go to their best recourse is to see a dentist, not to go with an antibiotic. And the tools that are available are a tooth pain prescription, there's a poster, and a frequently asked questions for patients. And then the other scenario is where there is evidence of systemic involvement, where there might be fever, malaise, trismus, difficulty opening up, a large amount of swelling that's spreading to their face, their pain management and an antibiotic is suggested, and then urgent dentistry follow-up for the definitive management. There is also, so there are two different charts. One is for a dental setting that I'm showing you right now. That first one was for a non-dental setting. And I won't go into detail in a dental setting, as this was a talk meant for primary care providers. They have a dental prescription very similar to that viral prescription that says, this is what we think you have, these are things you can do to help your symptoms, and this is what you should do for follow-up. So, cellulitis. Make sure that you have the right diagnosis, because sometimes cellulitis can be stasis dermatitis. Red legs aren't necessarily infection. Could be a DVT. It could be an insect bite reaction. Certainly seen lots of that, where you get a big swollen arm from an insect bite, and it looks so red and hot and uncomfortable, and you think, wow, it must be cellulitis. You really need to be careful not to overdiagnose a swollen arm from an insect bite versus cellulitis. So just that, I won't go into any more detail than that, but there are definitely mimickers, and a lot of people who aren't responding to antibiotics aren't responding because they don't have cellulitis. But if you do, and you've made that correct diagnosis, uncomplicated non-purulent cellulitis, the treatment is 5 to 7 days. Skin abscess, incision and drainage. If that skin abscess is greater than 2 centimeters, or you have MRSA suspected, then you would consider antibiotics for 7 days. The link on this slide, the AMMI guideline, it's a very nice description of the studies around these duration recommendations. So if you have questions about, hey, what are the studies behind them, this is a really great resource for you. It's the AMMI guidelines from 2021. So cystitis, how about bladder infections? Antibiotics are indicated, and the duration, though, can be shortened. Nitrofurantoin is a 5-day course. Beta-lactams and trimethoprim sulfamethoxazole is 3. Fosfomycin is 1 day. That's just the way it has always been. It's designed that way. Ciprofloxacin, and I bring this up, is not indicated first line. Ciprofloxacin is not indicated first line. Resistance is increasing, and the risk of C. difficile is increased. So I wanted to show you, and I hope all of you, or maybe if you haven't looked at an antibiogram for your region, these are really useful in certain circumstances where things aren't getting better. They give you an idea of what the sensitivities are of the bug for the antibiotic. So on this antibiogram from Ontario, we've got E. coli on this line here, and you have the antibiotic across the top. And you'll see that the sensitivity of E. coli for ciprofloxacin is about only 63%. Contrast that with nitrofurantoin, which is 96%. And then also make note that trimethoprim sulfamethoxazole is about 75%. So it just lets you know that nitrofurantoin for simple cystitis still has the best sensitivities generally across Canada. So how about stinky urine? This reads urinary tract infection, that smelly urine sign. It is likely bacteriuria, but is it a symptomatic urinary tract infection? Or did they just have asparagus last night? So, asymptomatic bacteriuria in the elderly, its prevalence increases with age and with fragility. In women, 25 to 50% as we get older. In men, and this is in age 65 plus, men 15 to 35%. If someone has an indwelling catheter for more than 30 days, it's 100%. So any urine that is removed from an indwelling catheter of more than 30 days duration is going to grow something. You have to look for other signs of infection. So overtreating as an infection is an international problem. Inappropriate prescribing has been found in 35 to 93% of antibiotic prescriptions for UTIs in patients living in nursing homes. So I should have put UTI in brackets. I would just say for people with bacteria in their urine living in nursing homes. So Public Health Ontario has put together this UTI program in long-term care, and this program in a group of, and Bradley could probably speak to this better than I, reduced urine cultures by 29%, urinary antibiotics by 41%, and overall antibiotics by 27%, showing you that the use of antibiotics in long-term care has a very large proportion of that is in the for people with so-called urinary tract infections, but really it's just asymptomatic bacteriuria. So this program says the first check mark is obtain urine cultures only when residents have indicated clinical signs and symptoms of a urinary tract infection. Obtain and store the cultures properly. Prescribe antibiotics only when the criteria have been met. Do not use dipsticks to diagnose a UTI. Dipsticks are notoriously inaccurate for diagnosing a urinary tract infection. And discontinue routine or annual admission screening if residents don't have signs or symptoms of a urinary tract infection. So this is another slide to talk about when should we order or look at the urine. You should look at a urine when someone has a fever of greater than 37.9 or 1.5 increase from baseline over 12 hours, as well as dysuria, if they have a urinary catheter, urgency, flank pain, shaking chills, urinary incontinence, etc., things that are like a UTI. If they have an indwelling catheter and no other signs of infection, plus a new costrovertebral tenderness, rigors, or new onset delirium. Now, that is if other sources of delirium have been ruled out. And I know how challenging this is, but you must look for other sources of delirium before zeroing in on a catheter-derived specimen of urine. And then another scenario would be new onset dysuria or 2 or more urgency flank pain, shaking chills. So these are just, again, guidance around what are the things that make you think that someone actually has an infection rather than just bacteria in the urine. As mentioned, use of dipsticks in the elderly. Public Health Ontario is not recommending using dipsticks. Choosing Wisely Canada and Public Health England. These are just 3 different organizations that have indicated that the use of urine dipsticks are they are not useful. They will overdiagnose and will result in unnecessary antibiotic use. So I like this. This is a Choosing Wisely poster. Reflect before you collect. Up to 50% of reflect before you collect. So before getting that urine, think about whether you really think they might have an infection. I wanted to bring up some other resources that are available for antimicrobial stewardship in primary care. This is from the website of Public Health Ontario, and they have a number under this. If you were to Google antimicrobial stewardship in primary care, there's a whole bunch of resources that you can click on that have some really that are useful, that I found really interesting. Now, I would encourage those who are family physicians or physicians in the group that you're able to get My Practice Primary Care. This is for primary care providers. It gives you a tailored report of your practice And there's a new component of it that tells you about your antibiotic prescribing. Now, this screen grab was for the family health team, so a conglomerate of physicians who work together. But the individual can get their own report that shows them their prescribing rate, that is the prescribing rate and duration. It gives information about how well they're performing on the initiation of antibiotics and prolonged treatment of antibiotics, and whether it is in the green zone, in the yellow zone, or in the red zone, where they are comparing themselves. You're being compared anonymously to others in your group, locally and provincially. So audit and feedback, and Bradley is very much involved in many of the publications around this in Ontario. There was a study of about 5,000 family physicians who got 2 letters with peer-compared case mix adjusted feedback with harms messaging, neither or both on total antibiotic duration and prescription. And the results are limited because only a third of people opened the letters. That's always a challenge. It's kind of like opening your emails. You hope people will open an email that you sent them, but that's absolutely not a guarantee. And so with this letter, the study, there was only 1/3 of prescribers opened their letter. But overall, the prescriptions were reduced by 3.5 per thousand. Long duration was reduced by 1.8 per thousand, and broad spectrum antibiotics were reduced by 2.4 per thousand. There was another study that looked at 3,500 high prescribers, and they were sent a single letter targeting antibiotic initiation duration compared to no letter at all, and they were comparing to their peers. And in this study, 4.2 relative difference in overall prescribing, and that sentence wasn't completed. $1.7 million less of antibiotics used, and an 8.1 relative difference in prolonged prescriptions. The Ontario Medical Association, CPSO, Ontario College of Family Physicians, and Choosing Wisely put together these QI in a box, quality improvement ideas that are that can be used in our CPSO quality improvement program. And there's a nice little antibiotic. This is not behind a paywall. If you were to Google quality improvement ideas CPSO, you would come up with this. And you can see one of these topic areas is antibiotics. It gives you an idea of how to do a quality improvement project or audit within your practice. There are also ones on benzodiazepines, opioids, PPIs, diabetes, pap smears, but that just for the purposes of this talk, I wanted you to see about the antibiotics. So that's the end of my formal presentation. Antimicrobial stewardship is in our hands, and I hope that some of this will give you tools and information that you might not have known, and tools that will help you to do the right thing.
Thank you so much, Dr. Young. That was super comprehensive and very practical. I think a lot of our audience will benefit from this, and I'll be recommending people to review the recording of this in the future. So we do have a few questions. With that, I will start with the first question that's here on the list, and it relates to kind of the checks and balances about having a delayed prescription. How do we know that they're actually being filled in a delayed fashion? So somebody asks, is there any checkpoint with the pharmacist on delayed prescription, specifically the day in which they are filling it, if it's not yet at the delayed point? I imagine this is very clinician dependent, but I don't know if you've had any experience with finding out from pharmacists or from patients if people are actually going too early to get their delayed prescription.
No, I don't have that. I would say because we are often working in a town with multiple pharmacies, it is, and I really, I do not get feedback from the pharmacist about when that is filled. So the information that is gained that we got from the Cochrane is based on studies that actually go and pursue people who have tried one tactic versus the other. And but I personally don't have a mechanism to have that.
Okay, that's helpful. I have a question here about the recent increases in the prevalence of Mycoplasma pneumonia. Um, so, in those situations where you suspect it might be the case, what would be your recommendation in with if the chest X-ray is negative, but you still clinically suspect that the patient has pneumonia?
It's a great question and very pertinent. I would treat with azithromycin if there was that prolonged cough, illness that's getting worse after 7 to 10 days. That's We just had actually Daniel Warshawski speak to the Ontario College of Family Physicians last Friday on a community of practice. So if you're interested in hearing a summary of what he had to say, he's a public health physician around mycoplasma. I would recommend listening to that community of practice with the Ontario College of Family Physicians. But his recommendation is really to treat with azithromycin and or doxycycline if there's an allergy and where you're really suspecting it.
Thank you. That's a great suggestion. Any advice on prescribing for patients with suspected pneumonia in which there's a delay in getting chest X-ray results? So maybe you're in a certain community where it's a bit harder to get chest X-rays done. Any suggestions on those situations?
So I'm trying to think of the scenario where an individual where you might be in a very small place that doesn't have a chest X-ray within. I'm trying to think of where that might be. Even small towns have ER departments. So yeah, I guess it is that in those situations you are left with your clinical suspicion, just how sick they are, if there are unilateral findings, if there's a very high fever, if worsening scenario where there is worsening illness and chest pain. But I wish I could say there is a combination of things to rule in pneumonia. Unfortunately, don't have that rule in combination of physical findings and symptoms to say with a greater degree of certainty. We do have the rule out where no findings you can be confident, but we don't have really a great combo for the rule in. So those circumstances are challenging for sure if you cannot get a chest X-ray quickly.
Mm-hmm. So it's really context and patient dependent for each case. What would you say about prescribing antibiotics immediately after catheterization in patients with long-term indwelling catheters? I'm presuming this patient does not have any urinary tract symptoms.
I would say don't do it.
Right.
Brad, you've been
In agreement. Yeah.
Yeah.
Yeah. I think this would be not necessary. Probably expose the patient to unnecessary therapy that could cause harm with little benefit.
Right, because the bacteria that does end up in there will be bacteria in the urine by as these studies are indicating, by 30 days you are going to be colonized with bacteria, and our skin has bacteria on it, and our bladders are not sterile vessels. They do have bacteria.
Right, the urine is not a sterile site. This is a thank you for a great review of important Choosing Wisely tools. And a question, are you aware of any successful initiatives outside of the primary care office that help to educate the public about appropriate antibiotic prescribing?
Choosing Wisely Canada has public-facing information and programs. They don't have a huge budget for big time public information campaigns. Brad, you'd probably be more able to answer what Public Health Ontario is doing in terms of reaching the public.
Yeah, we have some resources that can help clinicians have a discussion with their patients around the benefits and harms of antibiotic use. So there's a few resources called Let's Talk. If you go on our website under stewardship and primary care, there's some Let's Talk resources for the most common upper respiratory tract infections. And so that can be used in a variety of settings, most often primary care office settings, but we put those together to help clinicians have those conversations. From a broader perspective, nationally, there's the AMR Aware Canada website and campaign that's just launched, and that has a lot of great resources and tools and messages that can be shared with the general public. But as you said, like I think budgetary and support for national and local campaigns may be something that's needed in the future to help spread the message to the public about AMR and about
Yeah.
appropriate use.
And I would say I'm doing a disservice to a coalition that I'm part of, which is the Appropriate Use Coalition, that we've put together to the national organizations that are involved in appropriate use of medications in general, not just antibiotic stewardship, but medications in general, and that is trying to row the boats in the same direction and no not reinvent the wheel and spread the information through the various communication channels of organizations that are national and provincial in scope. And for example, the primary care appropriate use subgroup, I'm chairing that one. We are looking to spread the cold standard, which is what I just presented to you, spread that along those channels that are in the appropriate use coalition.
Thank you for that. Another question about UTI. Somebody says they wonder about considering delirium as a UTI symptom in patients who are catheterized because they're not able to present with some of the other typical symptoms, maybe dysuria or frequency. They're asking about UTI symptoms presenting as delirium only. Any thoughts on
Mm-hmm.
that?
Yeah, the studies we did try to find studies that differentiated just change in behavior with delirium and UTI. And the sorry thing about these studies, it's so common. Like I worked in Emerge and I can't tell you how many people come from nursing homes with change in behavior, the urine is dipped, then they get sent home on Cipro. It is and that ends up not being the actual problem. It is a really, really common problem. Appears to be a really easy number of like I can think of lots of patients even locally where we could get a study and do it, but it's just not being done. When we looked at the studies that were looking at it, they actually defined UTI by delirium and said, therefore, asymptomatic bacteriuria causes it. So it was a circular argument where there were no other symptoms besides change in behavior that gave that individual the diagnosis of UTI. So to your question though about not being able to ask them about dysuria, I think it's a very similar thing for people who have marked dementia or that they're not able to say it hurts when I pee, I'm peeing more. They're not, perhaps they are in briefs and you don't know if they're peeing more frequently. So it is a similar kind of a setting where you're going to have to look for other things that would suggest a urinary tract infection, like a pain, abdominal pain, and changes in their vital signs. That Loeb criteria, it goes over the suggestions of what you could look for.
Great. One of my colleagues, Dr. Jerome Leese, you may have worked with, has commented on the concept of premature diagnostic closure, and that if you assume that it's the urine is the reason for their patient's symptoms, you may miss out on other things. So I think that's an important point that you've
You really
emphasized.
do need to look for other things before you hone in on the urine.
Next question is, do you have any concerns with the use of tetracyclines for very short periods of time in any age groups? I'm not sure if that's around a specific, there's a specific concern there, or, but any
Yeah,
thoughts on
I'm
that?
outside of allergies, there isn't a specific. I'm not I don't know of there being a specific concern for short course of tetracyclines, like for example, doxycycline being the one suggested for mycoplasma, short course of doxycycline for exacerbation of COPD. I don't know of
Yeah,
any.
yeah. I believe the concerns around like use of tetracyclines in younger age groups previously stated are now not as much of a concern. That younger patients can still receive tetracyclines with respect to bone health and teeth health, that kind of thing. Um, so I'm not sure if that's what they're referring to or not. And then we have, if there's any other questions, we do have one question left, but feel free to type your question into the Q&A pod. Last question here is something that I get conflicting suggestions on is for Pseudomonas in the urine. What dose of ciprofloxacin do you recommend? For a specific question here.
Mm-hmm. I'm typically going with 500 BID if I'm treating a systemic infection, and I will go with 250 BID if I'm treating a cystitis.
Okay, yeah, thanks. That sounds reasonable to me as well. And I think important to note that Pseudomonas in the urine with symptoms, and if the
Yes,
patient actually has, yeah, because sometimes I think people respond to, oh, it's a specific bug, or it's a bug I'm not as used to seeing in the urine, or it's a resistant organism. All that still needs to be taken into the context of the patient's symptoms.
right. Yeah.
So I think that's the close of the questions. I just want to ask one final question maybe before we close. And you touched upon the My Practice reports, which I think have a lot of great information for clinicians to find out how they compare relative to their peers with respect to prescribing. But I think we know that in Ontario, only about half of physicians have signed up for these reports. As a user of the My Practice reports, would you have any thoughts or anything to share with your fellow physicians about signing up, any benefits or insights that you've gained from participating in that program?
Yeah, I have gained I got my feedback and thought, oh, I've always sort of patted myself on the back for being really good, and I thought, oh, it wasn't quite as good as I thought it was going to be, and so I had a look and I found some changes that I could make for example, duration of antibiotics and which I have been reducing over the last year and a half. So I would say that the data does have a bit of a lag. So if you've just recently made a change, then you might not see that on your My Practice report. There is also a section of My Practice report that looks at your opioid prescribing and benzodiazepine prescribing. And then it also gives you a snapshot of how you're doing in terms of screening and diabetes management, and then gives you an idea of how many people you have in your practice, what their age quintile, their age distribution, and income quintile, and gives you a sense of where you are in relation to your local group of doctors as well as the provincial group. So I've just found it a very interesting thing, not always humbling, but I think important for us to be open to that kind of feedback.
Great.
Yeah.
Thanks
Sorry,
so
and
much.
I do have two other questions. Communication about primary care, these recommendations, they are on the cold standard. We have circulated it with our family physician group just on the info digest that goes around to all family doctors in Canada. There was a sharing of the cold standard again to highlight what's in it and antibiotic duration. Whether people open it up fully and really drill down into that antibiotic duration, I don't know, but that would be the hope. And um, yeah, so that's really the main right now. That's what we are trying to push. It's a product that has been created by Choosing Wisely and the College of Family Physicians of Canada, and we are trying to disseminate it there. Yeah, and Bradley, you can the nurse practitioners, are they able to get?
Yeah, So there's a question here about, are nurse practitioners able to sign up for something similar to the My Practice reports? As of now, I believe the answer to that is no, but that's something that has been floated as a discussion point for an important audience for receiving these types of feedback, but I think it's a matter of being able to access those data. So I think those discussions have taken place, and that might be something to look for in the future.
For sure.
So I think that's probably, I just see one question just came in. Are there any infographics available on true UTI symptoms for residents and families? I see a lot of false symptoms on the infographic. I think we have some resources on the PHO website. If you go into publichealthontario.ca/UTI, there's a patient information sheet there from our UTI program. AMI Canada, Association of Medical Microbiology and Infectious Diseases Canada, has a nice campaign, Symptom-Free P, Let It Be. And for that campaign, they have a lot of great resources. Some of it includes information that can be provided to residents and families on what the symptoms are and what the symptoms are not. So I think that's probably a good place to check out resources. I'm not sure if you have any other ideas, Dr. Young.
The lobe criteria could be something that is up there on circulated as for that slide that I had showed earlier.
I'd like to thank you so much, Dr. Young, for the great presentation, and also extend my thanks to everyone who joined in for listening into today's rounds. As a reminder to everyone, save the date for topic. This is the Ontario Public Health Convention. It will be held March 26th and April 2nd in 2025. So if you're interested, check out the website www.topichc.ca for details. So thank you to everyone and have a great World AMR Awareness Week.